our fourth and final installment of maximizing third-party reimbursement through enhanced medical documentation and coding. Today we're going to take everything that was covered in Series 1 through 3 and bring it all together so that you can see all of the codes together, how they work. And just keep in mind, as we're going through the PowerPoint series, the information contained in this presentation is purely from a coding perspective. You should really take the time to follow up with your local state Medicaid agencies and entities, as well as any of the insurance plans that you participate with, to ensure that you are following their guidance so that you can get your claims processed and paid. So the intent of this presentation is to provide you with the coding information, but you really need to follow up with your insurance carriers for best practices in terms of how to get paid. So the learning outcomes, again, we're going to review the CPT and HCPCS codes along with the ICD-10 codes that was covered in Series 1, 2, and 3. We will look at some very specific coding scenarios which reflect the accurate reporting of the codes for AIDS and HIV medical care. We'll discuss the importance of proper code sequencing, also looking at modifiers when applicable, discuss the importance of proper documentation and its impact on your reimbursement. The next few slides are just the acronyms that were used in the webinar series. Alrighty, so let's look at our first polling question. We have about 4 of them for this series. What role do you play at your healthcare facility or center? Are you a clinical staff, such as a nurse practitioner, a medical doctor, or a physician assistant? Are you the office manager, supervisor, front desk person, patient registration? Are you biller, coder, insurance follow-up? Are you an IT person? I think we have had a few IT persons on the previous calls. So if you're IT, you would select other. So please select your option. Okay, it looks like everyone's about done. And it looks like the bulk of our webinar participants are in the other category. So I suspect that these may be our IT professionals. So IT, this is a good webinar series for you to have attended for the last 4 sessions, because this webinar series provides you with all of the coding information, but you need to follow up with your reimbursement department so that they can reach out to the insurance plans to get specific details on how to set that up in your systems. Okay, so in webinar series 1, we spoke about the E&M Service Codes. So this slide provides you an overview of the new patient visit codes, your 99201 through 99205. If you'll look, the 99201, in terms of the 3 components that we spoke about, your history, your exam, and your medical decision making. The E&M the 99201 for the components, the new patient code, you would have a problem-focused history, problem-focused exam with straightforward medical decision making. And then the 99202 is an expanded problem-focused history with an expanded problem-focused exam with your straightforward medical decision-making. So the numbers that you see here on the slide correlate to elements that are documented in the medical record that us auditors look for when we come in to do a chart review. The same applies with the established patient visit codes. Let's see, here we're going to pointer. Here are the elements that are used in reviewing the documentation to determine the history levels. Here, this one describes a 1995 body area or organ system exam. If you're using 97, then you would utilize a set of guidelines. But for your specialty, well, for the most part, if you're primary care or internal medicine or general medicine, you would be using the 95 guidelines unless, of course, your facility or your doctor's office decides to use 97. So the slides reflect the 95 guidelines. The preventive medicine visit codes are here for you as well. You have your new and your established patient visit codes here. Your 99381 through 99387 are your new codes. Your 99391 through 99397 are your established patient codes. These codes are selected based upon the patient's age. So, for example, if a 25-year-old patient comes into your office for the first time for a well visit, you would select the 99385. Versus if they were an established patient, you would select the 99395. So the preventive medicine visit codes are used for patients that are coming in for well visits. And typically when a patient presents for a well visit and the physician does any type of counseling, the codes that are at the bottom of your screen reflect counseling, but these should not be reported with the preventive medicine well visit codes because they're included in these codes. The next slide, and I thought we fixed this, and I apologize. The next slide is your preventive medicine counseling visit codes. And if you'll notice, these codes are time-based. So your 99401 is 15 minutes of counseling versus the 99402, which is 30 minutes. 99403 is 45 minutes. And 99404 is 60 minutes. And so if you look at the note at the bottom of the slide, these codes should not be reported in conjunction with the preventive medicine visit, well visit codes, because counseling is a component of those codes. And I think if that on a prior webinar series, I think it was one, we did speak about someone asked a question regarding if you can report the preventive counseling visit codes together with the regular E&M codes. That is purely a decision that is based upon the insurance carrier. The coding guidelines say, yes, you can do that, but the payer may come back to you and say, no, we're not going to reimburse when you report the two codes together. So again, it's very important that you follow up with the payer to get specific guidance from them, because they will guide you in terms of how you should be reporting your codes. They will guide you in terms of what they're going to pay for and what they're not going to pay for. We also spoke about the venipuncture code. Whenever a patient comes in for HIV testing, if your practice decides to not do the rapid, but instead decides to do blood screening, then when you report your E&M visit code, whether it's a preventive service or a sick visit service code, or even if it's a counseling code, you would report the code for venipuncture, which is 36415. Remember to also include a modifier, unless, of course, your payer decides that they don't want you to include a modifier, 25. The modifier 25 would be appended to one of the services that's here at the bottom of the screen. We'll see modifiers in a couple of slides. These are your HIV testing codes. So if you'll notice, these are your rapid tests. So if a patient comes into your office and the physician decides that they want to do a rapid test and get results on the spot, these are the codes that would be utilized. There are some additional rapid test codes on the next slide, but these are the most common rapid test codes that are performed, that are used nationwide. Most of the practices that I've worked with that have done chart audits for, they typically use OraSure or Alere. So these are your test, the most common rapid test codes. The rapid tests typically payable once every 6 months. But again, check with your payers. Some may say we're only going to pay for it once a year. It all depends. Here's some additional codes. So these are HCPCS codes. So we spoke about HCPCS codes in Series 2, your G0432 and your G0433. These are your rapid test codes that are for the HIV-1, HIV-2 combo tests. So if so you have these three different codes here. The antibodies, you have your EIAs, your ELISAs. These codes just describe the methodology. that was performed using these tests. So again, depending on what methodology your physician decides to use will determine which test code you would select for the HIV tests that you're going to perform in your office. These are some additional codes. These codes are not used by physicians. These codes are typically used by pathologists. So if you have a pathology or if you have a lab on site in your facility, these are the codes that the labs would use. If you're sending the blood test out, then these are the codes that the labs that you're sending the test out to, these are the codes that they would use. And so I know that some of the facilities that I've worked with, some of them have a lab on site, and some of them send the blood work off site to a lab, an independent lab that's responsible for processing the specimen. So let's recap really quickly. This is a true-false. E&M code 99211 is used to report a follow-up office visit encounter rendered by an RN. So this is a code. The question is asking if this code is appropriate for a nurse visit. Please cast your vote. Okay, it looks like we have 78% of our webinar participants say true and 21% say false. Looks like everyone didn't vote, but that's okay. But the answer to this is true. According to the Evaluation and Management Documentation Guidelines, CPT code 99211 is reported for a nurse visit. Typically, it would not be a code that's reported by providers, because this is a service that doesn't really require the necessity of a physician to perform anything. So, for example, patient may be coming in for a very quick service, such as a blood pressure recheck, or maybe they came in for TB testing during one of the encounters where there was an HIV test, but now they're just coming back in for TB recheck. That's typically when you would utilize the CPT code 99211 for a nurse visit, when the service does not require the physician physically present in the room. So modifiers we spoke about. We talked about quite a few types of modifiers. Modifiers was covered in Series 1 and 2. Modifiers are just two-digit codes, but in actuality they're not codes that you append to any type of service, but they are appended to the CPT or the HCPCS codes. Modifiers describe a situation or circumstance that doesn't change what's in the code's description. And there are CPT modifiers and there are HCPCS modifiers. Typically, some of the modifiers that we use impact our reimbursement. You shouldn't be reporting modifiers alone. And if you are submitting electronic claims, your system will not allow you to just submit a modifier, which is a good hard stop. But I've worked with some practices that are still submitting paper claims. And so if you are submitting paper claims, make sure that you don't submit any modifiers by themselves. Modifiers are never reported on ICD-10 codes. So again, if you're submitting electronic claims, your system will not allow you to append a modifier. You should contact your local state Medicaid agencies and your insurance carriers to find out which modifiers are appropriate in your state, because certain modifiers are appropriate for certain services that may vary across the scope, and also it may vary from payer to payer. So, for example, Modifier 25 is typically used to report E&M Service Codes between the ranges of 99201 through 99499. But there are some G codes that we didn't discuss during this presentation because it really didn't apply. But just as an FYI, there are some G codes that you can utilize modifiers on because that payer specifically stated that that's what they wanted. So even though The slide here says not to use them on HCPCS codes, on HCPCS lab codes. So you wouldn't be using this modifier on any HCPCS lab codes. But if you work in a facility where the payer has given you guidance to use a HCPCS code in place of an E&M code, then you would use the modifier 25 on that HCPCS, but not the lab codes. Ultimately, you should contact your insurance carriers to get guidance. There are 2 lab modifiers. The first one is modifier 92. The description is alternate lab platform testing, and it just describes a clear wave test. And the second modifier is QW, and it also describes a clear wave test. So in terms of these 2 modifiers, you should follow up with your local state Medicaid agencies and your insurance carriers to find out which modifier they want you to use. But in general, the modifier 92 is typically not reported on HCPCS codes unless your payer tells you to do so. This modifier would never be appended to your E&M service codes. So in general, these are only lab modifiers. They would only be appended to lab service codes. So again, just to reiterate, check with your payers to see which modifier they want you to use, modifier 92 or modifier QW. We also spoke about ICD-10 coding guidelines. And according to the official ICD-10 coding guidelines, the code B20, which is the code for the AIDS infection, correlates to the following terms: acquired immune deficiency syndrome, acquired immunodeficiency syndrome, AIDS, AIDS-like syndrome. So this slide gives you the overview of the terminology that's associated with the code for the AIDS infection, B20. We also spoke about HIV positive versus AIDS infection, and that they're not the same, and that they should not be reported together. So you would never report the AIDS infection code B20 together with the HIV positive code Z21 because they're not the same. Also, you would not report the HIV positive or the AIDS code with inconclusive HIV codes. So again, you have to make sure that you are able to review the coding guidelines and that you're able to apply them as you're coding your cases for the patients that are seen in your practices. If a patient presents to your practice from another locale or another region or another country, because that's the only, these patient types that come in with HIV-2 are not diagnosed here in the United States. They're diagnosed abroad in other countries. So if you are treating a patient that has the HIV-2 infection, you have to assign the principal diagnosis code B20 for HIV-1, and then there's a secondary code that describes the HIV-2. We'll see that in a moment when we get to some slides. Inconclusive HIV testing. Typically, newborn babies are born to moms that are HIV positive, and the babies may have the mom's antibody. They may have the mom's antibody status, but they may not necessarily contract AIDS or the HIV infection. Sometimes these newborns never become infected, and this is known as a false positive or an inconclusive HIV test. So there is a code for that, and if you are in a practice where you're treating the newborn babies, you would utilize the inconclusive HIV test code or the false positive code. So here are the codes that you are probably familiar with that were phased out on October the 1st. 042 for AIDS now became B20 for the ICD-10 reporting on or after October the 1st, and V08 became Z21. Some additional codes that you were probably using under the old coding system. Counseling, V6544, is now Z71.7. The screening code maps to 2 different codes in ICD-10. It maps to the HIV screening code, and it also maps to other viral diseases. So you can use the Z11 specifically for HIV screening, and if you're doing any types of screening for any type of other viral diseases that do not have their own specific code. Keep in mind, this old code B73.89 maps to two codes. But if you go to the code book, there may be other diagnoses, other viral conditions that have their own codes. But if they don't have their own codes, then you would utilize Z11.59. The inconclusive HIV or false positive code in ICD-10 is R75. And so again, just to reiterate, for treatment for babies that are that have a false positive status, you would report that as R75. Some additional codes that we spoke about in Series 3. Z20.6 is used for pre-exposure prophylaxis. It's also used for post-exposure. The high-risk sexual behavior code in I-9 was mapped to 3 codes in I-10. So you have high-risk heterosexual behavior, you have high-risk homosexual behavior, and you have high-risk bisexual behavior. The other problems related to lifestyle code maps to 1 code, Z72.89. Your human T-cell lipotrophic virus code, B97.34. This is the B9735 code that we were talking about for the HIV-2 virus. The Z41.8 is for encounter for other procedures for purposes other than remedying health state. If you look back in ICD-9, it was other specified prophylactic measure. So you'll see the terminology changes also in ICD-10. So you have to make sure that you know what the new terminology means compared to the older terminology. Z11.3 is encounter for screening for infectious with a predominantly sexual mode transmission. This is backwards terminology in I-9 was screening for a venereal disease. So again, there's just been a change in some of the terminology. Long-term use of medication in ICD-10, Z79.899. The terminology, other long-term current drug therapy. So if you have a patient that's on long-term use of any type of HIV meds, your code is Z79.899. And this code is here twice, and I apologize. At the bottom of the slide, you'll notice there are some special coding instructions. These coding instructions apply to the long-term use code. So in terms of patients that are on any specific drugs where you're monitoring drug levels, the coding instructions advise you to use the Z51.81. And here's an excludes to note. We said in our Series 3 that the excludes to note means that you would report these codes if they apply. So, for example, if you're treating a patient that's pregnant and they're on any meds and you're monitoring those meds, you now have 3 codes that you need to report. You would report your Z79.899. You would report the Z51.81, and you would also report the code that describes the pregnant patient, O as in Oscar, 99.32. There's a 6-digit, that's why there's a dash. We also spoke about patients that have AIDS-related conditions. Those AIDS-related conditions are known as opportunistic infections. So if you look at this slide, I put the most common AIDS-related conditions or opportunistic infections on the slides for you. You have your candidiasis or your thrush. This is the code range. CMV, this is the code range. This is the code range for your HSV, A60.00 to A60.9. So these are your code ranges for the most common opportunistic infections. So if you want the complete list, please be sure to visit the CDC's website. And then the CDC's website doesn't provide you with any codes. So if you are not a coding expert, you would just have one of your coders go to the code book and map the description of the opportunistic infection with a code, and then you will be able to assign a code for it. But these 2 slides just gives you the most common codes. Accidental finger stick. So if you have an employee, such as a medical office assistant or an RN or an LPN, or even a physician that accidentally punctures themselves with a needle after treating one of your patients that are getting HIV screened, there are 6 codes that you would need to select versus the 1 code that was available in ICD-9. Oh, that's messy. Let me fix that. Okay. So you have your contact with hypodermic needle, and we spoke about the 7th character, ADS, designates that A is the initial encounter, D is the subsequent encounter, and S is the sequela. The A just means that the patient is being treated and the condition is in its active phase. So as long as the patient is coming in for treatment during the active phase, the code that you would select the code that ends with the letter A. Once the physician has determined that the condition is no longer active and no longer requires treatment, that encounter would be coded as subsequent. If treatment is completed, but the patient comes back thereafter complaining, let's say they have pain in the area where the needle poked them, that would be coded as sequela, because now we're not dealing with the condition itself. We have a new condition as a result of the old condition. The bottom 3 codes are contact with a contaminated needle. So the first 3 codes are just contact with a needle, and the last 3 codes are just contact with a contaminated needle. So this slide just gives you the description of the alpha for the 7 characters A, D, and S, which we just spoke about. So again, it's active treatment, and if you'll notice in the under the alpha D, it says completes active treatment. Here are some of the well visit codes that we spoke about. So if you have a patient that's coming in for a well visit, or rather I should say they're coming in for HIV testing and screening, and they have a well visit during that encounter, you would report one of the well visit diagnosis codes as the principal diagnosis. You have 2 sets of codes. The first set is for your adult population, and if you'll notice, the Z00.00 denotes well visit without abnormal findings, and your Z00.01 is with abnormal findings. The original intent of the codes when they came out, the code that denotes with abnormal findings, typically this is reported when a physician examines a patient and there are lab or diagnostic tests that were ordered prior to the visit that the patient comes in for, and the physician physically has the results available and discussing those with the patient. If there's any abnormalities, you would report Z00.01. The codes are currently going to be under review for the next coming cycle to determine whether or not they want to continue with that definition of with abnormal findings, because there was a lot of confusion nationwide in terms of how to use the codes. So to reiterate, the codes that reflect with abnormal findings must have a diagnostic test or some type of a radiologic test, such as an EKG result or lab results or radiology results at the time of that well visit in order to report that. These are just some additional codes, well visit codes for newborns. I'm going to bypass that. Here are some counseling codes. So you have this B65.49 and ICD-9, which was other specified counseling, which now maps to these 3 different codes. Z70.0 is counseling related to sexual attitude. Z70.1 is counseling related to patients' sexual behavior and orientation. And Z70.3 is counseling related to sexual behavior and orientation of third parties, such as a child, a partner, or a spouse. So you have these 3 new codes that map backwards to this 1 code. The unspecified exam code has been clarified in ICD-10, and it maps to 2 codes. So if you have a patient that's coming in for a follow-up visit, typically let's say you're writing in the chart that the patient had a medical condition, but that condition is now resolved. You would report your Z09 code, and you would, in addition, report the diagnosis code that reflects whatever that medical condition was that was under treatment. So now, instead of reporting this unspecified code that was used in ICD-9 that commonly resulted in denied claims, there's a code that's more specific that helps the payer determine that the patient was sick, but now they've completed treatment and they're coming in just for that follow-up visit. Now, if you'll notice, Z08 is specific to cancer, and the Z09 is everything other than cancer. In terms of diagnosis coding tips we spoke about, never report AIDS or HIV positive if you're reviewing a record, or if the doctor is documenting that it's a suspected, suspicion of, possible, likely, rule out. So these are all terms that are synonymous with the doctor has not definitively diagnosed the patient with the AIDS or HIV infection. Instead, you should be reporting their presenting complaints, the chief complaint, the signs or symptoms. So if the patient comes in and they're complaining of muscle aches or rash, or they have swollen glands or ulcers, mouth ulcers or genital ulcers, then these would translate to a code that you would report instead of reporting AIDS or HIV positive. So in general, the medical record must clearly state that the patient has AIDS or HIV positive. Terminology which states active versus history of. Active translates to the current condition. So you would report B20 if the patient has a history. If the patient is actively being treated for AIDS or HIV, or you will report HIV positive code Z21. There is no code for history of, so it doesn't exist. And in terms of the reporting, if the patient's record says that they have a history of, you would map B20 if the patient's chart history shows a long-standing history of AIDS, or if the patient is HIV positive, then you would use Z21. But I tell my practices that I work with on a regular basis that when you see the term active or history of, to go back to the physician to get clear documentation, because when the payers come out to do their chart reviews, some of them are very strict. So in terms of the documentation, make sure that your providers are documenting very clearly that the patient either has the AIDS infection or the HIV positive status, or they don't. So you want that very clearly stated in the records. So now let's look at our next polling question. According to the ICD-10 official coding guidelines, AIDS-related conditions are sequenced as the secondary diagnosis code. True or false? Please cast your vote. Okay, so it looks like about 50% of our webinar attendees that voted, because I see there's 30 of us online, but only 15 voted. But in any event, 53% say that that's true, and 46% say that that's false. And the correct answer is true. According to the ICD-10 official coding guidelines, any patients that are diagnosed with AIDS-related conditions or opportunistic infections, always remember that that AIDS-related condition is sequenced as the secondary condition, so your code for that would be secondary, and you would report the B20 as your principal diagnosis. All right, so now let's look at some coding scenarios. Here's the part that everyone's been waiting for. Let's look at some coding scenarios. So this is a HIV counseling without testing. A 17-year-old patient presents to their GYN to discuss contraceptive options, and safe sex. The doctor counsels the patient on the various methods and suggests to the patient to take an HIV test. The patient agrees but then declines. So the physician counsels the patient for 30 minutes and asks the patient to reconsider the test at a later date. So this code was selected, this encounter was coded as counseling because this patient was counseled and there was no testing involved. The code 99402 describes 30 minutes of counseling, and the diagnosis code Z71.7 also describes counseling. And so the next slide just gives you the rationale. At the bottom of your slide, you'll note that there's a telling you to check with your payers. There are some payers out there that do not reimburse for the counseling codes. So you should follow up with them because they may have specific guidance telling you to utilize the E&M Service Code in lieu of the counseling code. So remember, everything ties back to what do the payers want you to do. The second scenario is a rapid test with preventive care. A patient comes in to their primary care physician's office concerned about recently having unprotected sex, and they request a test, an HIV test. This is a new patient, so the physician does the preventive exam and counsels the patient. They also do a rapid test. So this particular encounter is a new patient preventive medicine visit exam. So you'll notice we use the new patient preventive code 99385. The physician also did a rapid test. So at the bottom slide, you'll see, at the bottom of the screen, you'll see the code 486701. It was selected on the based on the methodology. Let's go back. Because during this encounter, there was a test, HIV test done, this particular payer wants the E&M reported with Modifier 25. There are going to be some payers that will tell you not to use the Modifier 25. So you have to follow the advice from your insurance carriers. At the bottom of the slide, you'll notice the modifiers 92 or QW. Depending on what your payer says, will determine which modifier you'll use for the test. And now let's look at the ICD-10 codes. The well visit code Z00.00 is the principal diagnosis. The HIV screening code is the secondary. Counseling is Z71.7, and high-risk behavior Z72.51. If you'll notice, the codes are different. Well, the principal diagnosis at the top is not reported at the bottom. So you have your screening code with your test, 86701, as the principal, your Z71.7, and your Z72.51. So you always have to make sure that, to go back, you always have to make sure that when you have multiple diagnoses on an encounter, that you map the diagnosis that ties to the procedure or service that was rendered, because if you don't, this service may be denied for medical necessity. Now, some payers may allow you to report Z00.00 as the principal for this entire encounter, and some may not. So the correct way to report it is how you see it on the slide. But depending on what your payer says, that would determine how you would report your diagnosis. So here is the rationale for what we just looked at. This was an initial preventive visit exam. It includes counseling, so we did not report a separate counseling code. We used the 86701. That was what the doctor selected. The modifier 25 was on the preventive service. You use a 92 or a QC on the rapid test, depending on your payer. The ICD-9 codes are here on your next slide. Your well visit diagnosis code, your HIV screening code, the counseling, and the Z72.51 for recently having unprotected sex. This one is similar. This is just an established patient, so the codes are all the same. The only difference is now we're using an established patient visit code. HIV testing with counseling, so somewhat similar. The only difference is there was no well visit component. A 47-year-old male patient presents to their PCP concerned about unprotected sex. The PCP spends 35 minutes counseling the patient and draws some blood and sends the specimen to the lab for processing. So this is a counseling visit. Even though this is an established patient, this was a counseling service. So 99402 with a modifier 25 tells the payer that there was blood work done as part of this assessment, as part of this encounter. So that's what the modifier 25 stands for. You have your Diagnoses codes, Z11.4, special screening, Z71.7 for counseling, and high-risk sexual behavior, Z72.51. The three diagnosis codes can map to all three of the three diagnosis codes maps to both of the CPT codes. That's why there's a box around it to let you know that you can report all three with both of the tests, both of the services on the slide. Again, you want to check with your payers, because if your payer does not reimburse you for counseling, then you have to utilize one of the E&M Service Codes. That's the reason why it says established patient, because this was an encounter where one payer wanted the physician to report the counseling service, but the other payer down at the other end of the spectrum wanted the use of the E&M code. So here's the rationale. 99402 was a patient came in for a blood test. There was a counseling, and the counseling code should have been on that slide, so I apologize, but there's your counseling service, 35 minutes of counseling. Your modifier 25 was on the counseling service code, and you have your diagnoses codes, Z11.4, Z71.7, Z72.51. This is an established patient coming in for HIV testing with counseling. So your established patient codes, your E&M codes for these services will be determined based upon the level of history, exam, or medical decision making. So this is a patient who's HIV positive. They come in for follow-up care, and the patient has a history of IV drug use. The physician spends about 10 minutes counseling the patient, documents an expanded problem-focused history, and draws some blood work, and sends the blood work to the lab. So this is a 99213 with a modifier 25 because of the additional service, which is the blood work. The patient is HIV positive, so the code Z21 is principal. There was counseling, so the Z71.7, and other problems related to lifestyle, Z72.89, because of the history of IV drug use. And then the next slides just give you the rationale. Post-test counseling negative results. So this patient comes in for their results, and the results are negative. So the physician counsels the patient for 30 minutes, and they discuss the importance of safe sex contraceptive methods. The physician gives the patient some literature. So here's your counseling code, your HIV counseling code, Z71.7, and high-risk sexual behavior, Z72.51. So if you'll notice, there's a variety of different scenarios here to assist you with some of those challenging issues that you may be coding in your offices. This is another established patient visit utilizing the E&M code. Let's go back to that one, have E&M. So basically it's the same, similar encounter. This one, because the patient came in for their results and the physician advised the patient that they're HIV positive, now there is medical care that's being provided to the patient. So the patient, the physician counsels the patient for 15 minutes, and now he's going to give prescription meds. They also, the physician also distributes the education materials, but now there's a treatment plan written in the chart. So there's a treatment plan and coordination of care that was involved with this particular encounter. So this is an expanded problem-focused history with low medical decision-making. And the final E&M for this encounter is a 993. The patient's HIV positive, so the principal diagnosis is Z21, and the physician counseled the patient, Z71.7. And so this slide just gives you the rationale for the codes that we selected. Same scenario, but now the patient has the AIDS infection. So the only change here is that the principal diagnosis is B20 instead of Z21. And here's your rationale. This patient comes in and they present for their results, and the physician advises the patient that they have the HIV-2 infection. So we said that the HIV-2 infection is not common here in the U.S. So this there's a note here at the bottom that says the patient recently relocated from West Africa, which is one of the countries that has a high prevalence of the HIV-2 infection. So keep in mind that you may get patients from other countries that come into the U.S. To visit family members, or they may relocate to the U.S. And so in keeping in mind that situation, you may have to provide care to a patient that has the HIV-2 infection. So the principal diagnosis is always going to be B20. The secondary diagnosis reflects the age, the HIV-2 infection, B97.35. Oops, sorry. Ooh. Okay, now how do I stop that? Okay. Oh, wow. Okay, I apologize. I did something, and I don't know how to stop it. So the principal diagnosis is B20.
Everything looks okay on our end.
Oh, okay. So you don't see me doing this?
No, we don't see you doing anything.
Oh, you don't even see when I check the things off? Okay, let me keep going. So the principal diagnosis is B20. The secondary diagnosis is B97.35. And because the record says that physician counseled the patient, you have your HIV counseling code, Z71.7. So the next slide just gives you the rationale for this scenario. Antiretroviral therapy for a newborn. An HIV-positive mom brings her baby to the pediatrician for a follow-up visit for the 2-month-old. The physician documents an expanded problem-focused history and performs a brief exam. He reviews the lab results and decides to modify the medication. He also revises the treatment plan and tells the mom to bring the baby back in 1 month. The E&M level is for an established patient visit, 99213. This is false positive or inconclusive HIV test, R75, and Z20.6 for pre-exposure prophylaxis. And here is the rationale for the codes that we selected. Oh, all righty. Office visit related to AIDS. So this is a patient that has a history of AIDS. They come into their primary care doctor's office for complaints of fever and extreme fatigue. The physician documents an expanded problem-focused history. They examine the respiratory system and give the patient a prescription for antibiotics. The final diagnosis is pneumocystis carinii pneumonia with AIDS. So this is a patient that has an AIDS-related condition. So the principal diagnosis is B20, and the secondary diagnosis is B59. And this is in accordance with the coding guidelines that says anytime that a patient has any AIDS-related conditions or opportunistic infections, the AIDS is sequenced as the principal diagnosis. Any patients that have opportunistic infections would no longer be diagnosed as HIV positive. Once they have an once they have an opportunistic infection, they're now diagnosed as AIDS or the AIDS infection, so that B20 would always be sequenced as the principal with any of those opportunistic infections. So here is the rationale for the codes that we selected. Just wanted to make sure everyone was awake, so we changed it up a little bit. Here's another scenario. A patient with a history of AIDS and post-op total abdominal hysterectomy, presents with complaints of nausea, vomiting, and dehydration due to chemotherapy. So they came into the office earlier for chemo treatment. The patient also needed refill of their meds, so the physician does a detailed history with moderate medical decision-making. And the final diagnoses are nausea, vomiting, and dehydration due to chemo. Because the patient is still receiving chemo treatment, the diagnosis for the cancer is reported, and the patient just so happens to be a patient that has a prescription refill for AIDS, so you would also report the AIDS diagnosis. And we forgot the prescription refill diagnosis, I apologize. But the reason for the patient coming in is nausea and vomiting due to chemo, so the principal diagnosis is R11.2. It's dehydration due to chemo, E86.0. Patient still being treatment, is in active treatment for the cancerous condition, C53.0. They had an adverse effect of the cancer drugs. That's your T45.1X5A. And the last two, which you only see one here, B20 for the AIDS. And then there's a prescription refill code. And I'll remember it off the top of my head, but it should be at the end on some of the other slides. The rationale for the codes that we reported. Your diagnosis codes. This is a visit for a pregnant patient. 5-month pregnant patient comes in with a history of AIDS, and they go in for their regular prenatal visit. Oh, I'm sorry, they go in for an appointment, but they're complaining of severe cramping and heavy bleeding. And the physician documents a comprehensive history. The medical decision-making included IV meds, and then the patient was sent to labor and delivery. Now, because this patient, the condition was compromised because of the pregnancy, this is a high-level established patient visit, level 5. This principal diagnosis for this patient is O as in Oscar 20.0. The patient's condition, AIDS, according to the coding guidelines, if the patient in question is pregnant and has the AIDS virus, the coding guidelines state that you have to report a code that establishes that. So that code is O as in Oscar 98.712, and then you would also report B20 as the third code. And here's the rationale for the E&M level that was selected. And here's the rationale for the diagnosis code. At the bottom of the slide, it says that the patient is a symptomatic AIDS and there are no complications. Then you report 098.71 and Z21. So the scenario that's on this slide details a patient that has complications. If they come in for a routine follow-up and they don't have any complications, then you would report the O98.71 and the Z21. This is a medical office assistant that works in a doctor's office, and they were drawing blood work on a patient that has AIDS and they accidentally punctured themselves. The manager fills out the workplace injury forms, and the physician sees the medical office assistant, does a detailed history, a problem-focused exam, and the medical decision-making includes blood work. He gives the patient a 48-hour of post-exposure prophylaxis medication, and he counsels the patient. This particular visit, they draw bloods, and they send the blood work to the lab. This is a new patient visit because there was no record of the medical office assistant having been treated by any of the doctors in this practice. So the 99203 with the modifier 25 tells the payer that the patient had another service, which was the blood work. The principal diagnosis is for screening, Z11.4. You have your pre-exposure prophylaxis, Z20.6. Your counseling code, Z71.7. And because the patient was stuck with a contaminated, the patient in this case, meaning the medical office assistant, was stuck with a contaminated needle, the fourth code is W46.1XXA because this is their initial visit. And if the patient comes back in and they're still being managed by this physician, you will continue to report the code with the alpha A until treatment is completed, in which case the last digit now becomes a D for subsequent. Here's the rationale for the codes that we selected. So some closing comments. HIV testing with preventive medicine services. The preventive medicine service codes will be reported. If it's a new patient, based on the patient's age, you would select one of the new patient codes. If it's an established patient, you would select one of the established patient codes based on the patient's age. Because remember, these codes are selected on the basis of the patient's age. If the visit is just for counseling with no testing, depending on the payer, you would select the counseling codes. If the payer tells you that they do not reimburse for the counseling codes, then you would select the regular E&M visit codes, the 99212 through 99215. 99211 is here on the slide, but remember we said this code is only utilized for visits that involve nursing care only. Ultimately, you should check with your payers to see which code sets they want you to report. And remember, the guidance will vary from payer to payer. HIV testing with HIV pretest with testing and any preventive services. So again, you will be reporting the preventive medicine codes without counseling codes because the preventive medicine visit codes include counseling. Any modifiers that are approved by the payer should be used for the services. So these are just some wrap-up tips that we spoke about in terms of reporting. The rapid HIV test with counseling. We looked at some of those scenarios. Rapid HIV testing with counseling without preventive medicine. The confirmatory tests are typically performed by, reported by pathologists. So if you have pathology in your practice, they would be using the codes. If you're sending these out, then you would not be reporting these codes. Now, because historically reimbursement was driven based upon the CPT code that you selected, your 99212, your level 2 code, established patient visit, versus your level 3 established patient visit, historically it was based upon those codes. But now everything is shifted to diagnoses. And so it's very important that when your physicians in your practices are treating the patients, that they report all of the diagnoses that reflect the care that they're providing. Because reimbursement has shifted to incorporate diagnoses and the how sick the patients are and how well the care is being managed. And more importantly, the diagnosis codes for AIDS and HIV positive map to those chronic condition risk pools. And it's important that you make sure that you're capturing all of that. Because I've gone and done presentations and webinars and chart audits where the doctors are treating patients that have all these conditions. So when the patient comes in with an acute complaint, they only address that acute complaint. But you have to factor in those chronic conditions, because if you have to give any additional medication, the acute complaints that you're addressing, the medications that you may prescribe may interact with the medications that the patient's already on. So in theory, you are addressing the patient's total needs, not necessarily just their acute care needs at the time when they come in. Depending on the insurance plans that you participate in, and whether or not they are using the chronic risk-based model, all your patients are being assigned a risk score. And so if you are not reporting the diagnosis codes, you're impacting the risk scores of your patients, and you're ultimately impacting the revenue that your practice is going to receive. So your diagnosis codes are very important. Anytime the patient comes in for an acute problem, make sure you address all of their make sure you address the acute problem, but also address the chronic problems, because the chronic conditions greatly impact your risk-based reimbursement and your quality incentives. So there's a lot of QAR and HEDIS money out there that tie into the chronic conditions. Very important that codes that you report on your health claims match the information that's documented in the medical record, because they'll come out and they'll do a chart audit. And if they do a chart audit on a small sample of the records and they determine that you failed that small sample, the presumption is that you failed across the board. So they will extrapolate and take back money for everybody in that sample. They'll take back money from everybody in your practice that has the same diagnoses based on the sample that they've audited. So you have to make sure your coding is accurate and your documentation is accurate. Code sequencing is very important in terms of the electronic billing systems. If they're set up properly, if you sequence a code that is designated as a secondary and you sequence it as a principal diagnosis, when it goes out to the payer, the claim's going to deny, because they're following the coding guidelines. If that code is not deemed as a principal diagnosis, it's going to reflect and it's going to cause your claims to deny. So you have to make sure that any codes that are designated as a principal, those are sequenced as the primary diagnosis only. Any codes that are designated as secondary only, you sequence those as secondary. Same thing applies with the procedure codes. When you're reporting on an encounter for a patient that comes in for blood work, the routine venipuncture code, and you do any type of service where you're going to also report your E&M code, the 36415 should not be sequenced as the first code, because that is going to also affect your reimbursement. So you're always going to make sure that the E&M code is sequenced as the principal. We were just talking about diagnoses. B20 is always sequenced as the principal diagnosis anytime you're treating a patient that has any of those opportunistic infections. We also spoke about the terminology, possible, suspicion of, rule out. Anytime a medical record states any of the terminology that's here on the slide, the presenting complaint should be reported as the final diagnosis, such as muscle aches, rash, or mouth ulcers or genital ulcers, fever. You have two options. You can report these, or you can query the physician. If the physician is readily available in your practice, you can query the physician. If you query the physician and they tell you, yes, the patient has AIDS, or yes, the patient is HIV positive, they have to go back and change that note to state that. You can't diagnose, you cannot code based on a conversation, because that's still not considered appropriate coding. We spoke about active versus history of. So again, in a nutshell, make sure that your doctors are documenting properly in the record. History of and active, they don't exist in terms of the codes. So you should get your doctors to properly document so that everyone is on the same page in terms of what to code and how to code. And also in terms of when you have auditors that come in, you want to make sure that your documentation is very clear so that they don't find any reasons to, when we come in and we do audits, we use an audit tool that has a point system. So we deduct points and we deem certain levels or certain areas non-compliant if the documentation is incomplete or inaccurate. If you're still using paper charts, beware. The first thing I would say is that the nation is moving to electronic medical records, and in terms of that shift from paper to electronic, the government is going to start to come after doctors and well, mostly doctors, because most of the hospitals are all on electronic. But the government is going to now start to look to come after doctors that have not moved to electronic medical records, and you're going to be fined because of the use of the paper charts. So if you're still using paper charts, try to stay away from the use of the up and down arrows because those can be misinterpreted. Instead, you want to utilize hyper or hypo, if that's what you mean, instead of the up and down arrows. Each visit must have a date, and each visit that ties into a patient who you've been treating for a long period of time must stand alone. So if an auditor comes into your practice and reads a chart that says see previous note, this note is considered incomplete because each note must stand on its own. Chronic conditions that are documented in one note must be redocumented in every subsequent note, because we don't go and look at a previous note unless we're coming in to audit a hospital facility where we have laterality to look at the notes that correlate to the admission and the discharge. But when we come into an outpatient practice, every note stands on its own. So every note must clearly tell a story. Why did you see that patient? What medical conditions did you treat? Coding from the problem list is unacceptable. Especially CMS mandates that you evaluate medical conditions that are listed in the problem list. So if you have a problem list that you utilize in your EMRs, you want to make sure that you notate the status of each of those problems in that problem list. So here's an example, a short example of a problem list, medical conditions that the patient that was documented in a record. So the HIV positive status is stable on meds. The patient also has a diabetic neuropathy. The medications were adjusted. They have congestive heart failure and COPD. It's compensated. They ordered some tests for the COPD. The hypertension is controlled, and the hyperlipidemia, the patient is stable on meds. So you always want to give the status of each of those medical problems that you document on a problem list. So this is our final polling question. So this patient returns for their test results, and they also need prescription for their hypertension medication. The physician sits with the patient, tells the patient that they have AIDS. He counsels the patient for 15 minutes on the importance of safe sex, distributes education literature, implements a treatment plan, and he checks the blood pressure and notates that the pressure is unusually high, 143/90. The hypertension meds are increased. The physician also tells the patient they need to see a nutritionist, so he gives them a referral, and they document an expanded problem history with moderate medical decision making. This is a true-false. The principal diagnosis is inconclusive HIV test result. True or false? Okay, looks like everyone is not sure of their code selection. Okay, so the question was, the principal diagnosis is inconclusive HIV test results. So if you go back to the scenario, it said that the physician discussed with the patient that they have AIDS. So this one is false. The principal diagnosis for this patient who was recently diagnosed with AIDS is B20 Your secondary diagnosis is for counseling, Z71.7, which is here on the slide for you. The hypertension code, I-10. Here's your prescription refill code that I was talking about. So when patients come in for prescription refills, it is acceptable to report the prescription refill code. However, it's not acceptable to report just the prescription refill code. Your claim or the encounter should include the medical condition that the physician will be dispensing the prescriptions for. So in this case, we were asking more about the principal diagnosis for this encounter. So B20 is the principal diagnosis, and the prescription refill code is for the hypertension meds. So closing comments, documentation and coding is extremely important. It drives your reimbursement. So you should make sure that anytime a patient comes into your practice, you want to, obviously if it's for an acute problem, you want to address their acute problems. But if they have other chronic conditions, you want to address those as well, because they greatly impact the reimbursement that you're going to receive for the quality measures that are being tracked by the government, your state government, your local, and the federal government. You have QAR, you have HEDIS. If you have a Medicare population, they're looking at the HCC risk adjustment. So you have all of these different quality measures that are being tracked at every level of the government. Report all of the diagnoses that reflect the care that was rendered, and you want to make sure, specifically for your Medicare population, when they come in at the beginning of the year, even though they're an established patient in your practice, it's very important that you go back and you re-document all of the conditions that you were managing the prior year, because what CMS does for your Medicare patients is they wipe the slate clean of all of their diagnoses. They archive those, and they expect that when the patient comes in for the first time next year or for the following year, that you will evaluate those conditions. If you don't evaluate those conditions, the patient's chronic condition score dips significantly. And when what you're telling the CMS is that the patient, their condition has now improved, but in actuality it hasn't improved. So you want to make sure that you are documenting all of the conditions that tie into the care that's being provided. And I think we have a question here. So just to clarify, if the patient presents for an acute problem that is not AIDS or opportunistic or age-related, that problem should be coded first. Absolutely. Remember, in terms of coding, think, well, why did the patient come today? Whatever reason the patient presents for, that would be sequenced as the principal diagnosis. The exception to the rule is if any of those chronic conditions exacerbate and the time spent by the provider is spent trying to manage that particular condition, that would change the sequencing of your codes. So if the patient comes in for an acute problem, the chronic conditions are stable, but the patient we just need some meds, you're going to document patient has AIDS, they're stable on their meds, but they need a prescription refill. That acute problem is the principal diagnosis. The AIDS condition has been factored in because they ran out of their meds, and so you're going to document that, the patient's stable on their meds, they're compliant with their meds. I think we should have talked about the compliant codes. There are some codes out there that describe when a patient is compliant with medication or compliant with treatment. You should also take some time to go look for those codes. It's very important that if your patients are non-compliant, that you also document that in the record and you also code that, because that also factors in to their healthcare needs down the road. So back to the slides. Medical record documentation must support the services that's submitted on the claims. So this does not just apply to your Medicaid agencies. This applies across the board. Any claims that you submit from your practice, your documentation should correlate to whatever is in those claims. All right. Documentation should substantiate and support medical necessity, and it should also support all of the diagnoses that you report on that claim. Any documentation inaccuracies result in payment recovery and sometimes heavy sanctions and fines by the Office of Medicaid Inspector General and also the Office of Inspector General that oversees the Medicare program. So remember, you're dealing with two levels of IG. You have the Medicaid IG and you have the Medicare IG. So you have to make sure that your documentation is consistent for all of your patients. You don't want to deviate and tamper with your documentation because of, based on the patient's insurance type. Document consistently across the board so that there is no ambiguity or any room for anyone to come in and say, well, you document this way for this kind of patient and you document a totally different way for another patient type. Make sure it's consistent across the board. Sanctions and penalties from the OIG, whether it's Medicare or Medicaid, include restricted or excluded participation from the Medicare program for the Medicaid program. They can terminate your provider status. They can terminate your license. There's huge fines, and then there's jail time, which we don't want. We don't want any of these to impact your ability to provide care to your patients. So ultimately, you want to document properly, and you also want to make sure that your coding ties to whatever you're documenting. This is just a list of the web resources that we use for the presentation: CMS, Food and Drug Administration, the AMA, NCHS, and CDC. I think I see a question. Question about the use of the 99211. First blood drawn and swabs done to send to a separate lab. Second visit, patient comes back to get results, verbal or written. They have to be written. All negative results, nothing significant to discuss. Does this second visit warrant 99211, or would results be considered part of what was paid with visit 1? Whenever a patient comes back in for their results and their results are negative, typically you would use your counseling codes. You should follow up with your payer to find out if the counseling codes are acceptable. Because from a coding perspective, you're just counseling the patient, giving them their results. You would use the counseling codes because you're just discussing the results. So you have to follow up with the payer. Your 99211 typically is only used for your RN visits. For your medical doctors, you should be using the 99212 or above, depending on the level of care that was provided. And so let's go back. When you're discussing the results, that would count as a low medical low medical decision making. So you would have to follow up with the payer. Like I said, I would go with the 99401 through 99404 codes, which are your counseling codes. But your payer may say, no, we don't want those. We want the established patient visit codes. In which case, then it would be a 99212 with D09. Remember, we spoke about the return visits for completed care. So you could use that along with the counseling diagnosis code. Does that answer your question? In the meantime, here are the web resources that were used, additional web resources that were more related to coding. AAPC, AHIMA, the American Academy of Family Physicians, American Hospital Association. Other resources, very important that your practice ensure that you're using current coding books. I went and did a coding in-service for a practice, and they were concerned about their claims being denied. So I did a random review of some of the claims, and the codes were outdated. The codes no longer existed. And so I asked to see the coding resources that they were using in their practice, and they were using code books that were 5 years old. So I explained to them that it's very important that you use codes and code books that are current from year to year. Every year when the code books update, you should be updating your system with the most current codes, and you should have code books that reflect the most current code set so that the staff in your office that's responsible for doing the coding can code properly. If you're using old code books, you can't hold them responsible for assigning codes that do not exist because that's what's available to them. So you have to use the most current code sets that are available. So now I'm going to turn it back over to Samantha. I'd like to thank everyone for joining the 4 webinar series that was provided by HealthHIV. So Samantha, take it away.
Thank you so much, Stacy. I'd like to thank everyone for staying with us through the 4th webinar. If your organization would benefit from technical assistance on billing practices or any other topic, please send me an email, samantha@healthhiv.org. Also, Stacy is wonderful at answering questions very quickly, so if you think of anything now or anytime in the future, please send us an email, and I'm happy to put you in touch with her. And I know some of you might not have made it for the first few parts of the series for the webinars, so they will be on the Target Center by next week. So we'll have all of the recorded webinars as well as the resource packets and the original slides. And thanks again for staying with us through this 4-part series, and we hope to have you on another program in the future. Take care, everybody.